I'd like to thank SAGES for the opportunity to present today. My name is Adam. I'm a bariatric surgery fellow from the University of Toronto. My only disclosure is that part of our fellowship is funded through a fellowship grant, but that's not relevant to today's talk. So I'll be talking about unexpected histopathological findings in sleeve gastrectomy specimens. So as we all know, the sleeve gastrectomy is currently the most commonly performed bariatric procedure in North America, and that's increasing. So the most recent data shows that it's about 60% of all procedures. Obviously, as the number of these procedures increases, so does the number of specimens that are submitted to pathology for analysis. And there are a number of studies that have looked at what the findings in these specimens are. Unfortunately, the results are very, very varied. So they range from 20% up to 100% of specimens having some kind of abnormality in them. And also in this context, the role of preoperative endoscopy, specifically in sleeve gastrectomy, is still unclear, with various societies offering differing opinions. So what we wanted to do was look at our own population and identify what the incidence of these unexpected findings were, as well as identifying how many of them actually mandated some kind of change in postoperative management or follow-up. And also determine, based on our approach to a preoperative endoscopy, how many of these were actually identified before surgery. So we looked at our sleeve gastrectomy population. We looked at 222 consecutive sleeves at University Health Network. Our center has a selective approach to preoperative endoscopy. So basically, patients that have upper GI symptoms such as reflux, epigastric pain, or dyspepsia, or have a suspected hiatal hernia based on some kind of preoperative imaging will undergo upper GI endoscopy, but otherwise they'll just proceed directly to surgery. We then classified the findings in their specimens as either normal or abnormal, as well as whether or not they required some kind of change in the postoperative management or follow-up to these patients. So just our baseline patient characteristics, nothing too surprising. Like most bariatric surgery studies, most of the patients were women, mean BMI of 51.2 all around, average age in the late 40s, early 50s, and based on our approach to upper endoscopy, a little less than a quarter of the patients actually underwent preoperative EGD. This is what we found when we analyzed our all the specimens. So a little over half of the patients actually had strictly normal gastric specimens. About a quarter of the patients had some form of gastritis, and in smaller and smaller quantities, we ended up finding a number of other pathologies that in many cases are clinically irrelevant, such as PPI-related changes, funded gland polyps, but we did find a number of neoplastic findings, both benign and malignant. And when we look specifically at findings that changed or impacted the way these patients were followed up or treated after surgery, there were 8.6% of patients that had these findings. We then sought to identify whether or not these patients were more likely to have undergone preoperative endoscopy or not based on our approach to screening endoscopy. And they were significantly more likely to have undergone preoperative endoscopy. And in fact, when you exclude the patients whose diagnoses or histopathological diagnoses were found during that preoperative endoscopy, the rate of findings that changed our management after surgery dropped from 8.6 to 4.7%. We looked at age, sex, baseline BMI. None of these things predicted abnormal findings or findings that impacted our postoperative management. And the findings that did change our patients' follow-up or treatment included H. pylori infection, intestinal metaplasia, GIST, ECL cell hyperplasia. We found some neuroendocrine tumors, one case of carcinoma, a number of cases of atrophic gastritis, and one gastric lymphoma. So again, significant number of patients that had findings that impacted a change in their postoperative management. And this number is obviously fairly concerning if you take into consideration that Some patients may not be undergoing preoperative endoscopy, and these findings may go overlooked and may never be found if the patients are undergoing a procedure that either prevents further endoscopic assessment of the upper GI tract or does not generate a specimen like the Roux-en-Y gastric bypass. And also utilizing our approach to selective upper GI endoscopy, we were able to decrease that rate from 8.6% to 4.7%. And these findings are consistent with the one other study that was published on this topic by a group at the University of Pennsylvania. Our conclusions, essentially half of patients will have a normal sleeve specimen. A significant portion of these patients, however, do have findings that will impact the way they are managed after surgery. Using a selective approach to upper GI endoscopy, we are able to identify, in our case at least, about half of these patients that had a diagnosis that impacted, a change in their postoperative management. It's very likely that a universal approach to preoperative endoscopy may in fact increase this rate of identification and impact surgical decision-making prior to the surgery. Thank you, and I'd be happy to take any questions.